Thank you very much, Chair. It's a great honor for me to be invited to address this technical working group. Lesotho is landlocked by South Africa, is 30,000 square kilometers. And all the land in Lesotho is above one kilometer above sea level. So Lesotho is, has a prevalence of HIV prevalence of 25%. And as you can see, the districts have different prevalence. There are high burden districts which account for 71%, 75% of the population. The government is looking after 5 districts, and there is commitment, great political commitment and financial commitment from the government of Lesotho. As you can see, the younger people, especially females, have HIV. And this is the future generation. And as you can see, the women peak early and they catch up later at the age of 40 to 44. Test and treat was used as a strategy because Lesotho has more than 7,000 new infections a year. So it puts us to #1 in the world. And with TB, we are #1 as we speak. So what are we going to do about it? We only have 1.9 million people. So if we didn't act, we'd be wiped off the map of the world. So the Right Honorable, the Prime Minister of Lesotho, launched the test and treat on the 14th of April, 2016. And by the 1st of June, we had rolled out. We gave ourselves the 3 months to prepare. A detailed implementation and capacity assessment is ongoing, which will inform an investment case for Lesotho. It is very clear from this slide that we need the 4th 40 so that we can close the tap of new infections. Yes, we can treat. Yes, we can buy ARVs. But if you don't stop new infections by having mixed interventions of prevention, we're going to have a big problem. It's then estimated that 314,000 of people live with HIV in Lesotho. So if we take 90% of that, it means that we'll have to find 283,000. Of those, 283,000, they have to be on treatment. So 254 should be on treatment. And 90% of those should have viral suppression by 2020. And yes, these are big targets. How are we going to do this? What is our strategy? We have 6 interventions in our strategy. The first intervention is to implement test and treat, to cascade training methodology with close involvement of district teams to ensure quality. Strengthen advocacy, communication, and social mobilization by all the structures of governance, the traditional leaders, the church leaders, civil society, and positional leaders, in the politicians. And the launch has to be done by the head of government. That is the trick. Enhanced HIV testing, revised testing guidelines informed our test and treat. We adopted, and practiced the 2015 WHO guidelines. Improvement of referrals and service quality in HIV testing. It is very important that since we have a task shifting and nurse-led HIV program, we also have lay counselors, and many of whom are people living with HIV. An expanded model of provider initiative testing, index testing, and targeted community center testing This is driven by a coalition of government, the private sector, churches, and implementing partners. We are considering self-testing. As we have seen in other countries, it is already being done. System strengthening, increase the number of and capacity of human resources for health. Viral load testing, scale up for national coverage. Strengthening the last mile delivery of commodities and medicines. Supervision to ensure clinical quality. And data. We have to have data at source for transparency, accountability, and decision making. Coordination and collaboration and solidarity to ensure that we are singing from the same hymn book. The National AIDS Commission, the Ministry of Health, and other ministries, workplace programs, church groups, and traditional leaders and healers. To enhance decentralization, aligning ourselves with the local government structures, and harmonizing funding, and investing in evidence-based primary care, proven primary care interventions for maximum yield. This will help us to look at sustainability and investment case for Lesotho. Increase the coverage, finding and enrolling patients who have been waiting, who were kept out by us as a health sector to say, you're not ready yet, wait for your CD4 count, and they fell through the cracks while waiting because some of them had to walk for 20 kilometers. Optimize service delivery. Why should we expect people to come to our clinics and be told, we have to count your tablets, come back again, but these patients, this is a life and death issue. Why don't we trust patients? So we need to shift that mindset. Patients are trustworthy when they're given the opportunity to do things right. And we have to use the task shifting model. Tomorrow, we'll be presenting this at 7 o'clock. So we'll go into more details tomorrow, but it's very important that pre-heart and TB HIV co-infection, identify new positives, family members and adults, enhancing M&E at site level, and newly diagnosed people. So we'll go into details. Now this is where you can make it. This is, the slides show the Right Honorable, the Prime Minister, Dr. Pakati Thabang launching the test and treat on the 14th of April, 2016. And the young fellow below wrote the first prescription that day. So on that day, the first 8 patients for test and treat were initiated. Training, sensitization on new guidelines continued in all supported districts. Resources to be available for tracking pre-heart patients. And we front-loaded this initiative with 100 million rand for drugs and 2% of the Lesotho recurrent budget as a contribution to show our commitment. So the results, they speak for themselves. The shortest bar was data collected for 3 months, October to December 2015, 1780. January to March 2016, 1906. At the end of April, after we announced test and treat, 1,886. At the end of May, but now, when we do the rollout, so you can clearly see the yield of test and treat. Critical factors to success: political leadership government commitment. 47% of the HIV program is run with the taxpayers' money. 70% of ARVs are bought using Lesotho taxpayers' money. First line of TB treatment, Lesotho taxpayers' money. So the money, the commitment has to be there. Strong partnerships with everybody, state and non-state players. Technical leadership as a collective, and maintaining flexibility. You can build the ship as we sail. And the science is clear. I hope today you are all convinced that this is the right thing to do. That is our mode of transport. Those are the beautiful mountains of Lesotho where people live. We can no longer accept that these are helicopter sites. People live there. Let's use the traditional healers, the people in the community, and let's have full-time outreach services. And above all, partnership. May I thank the staff of the Ministry of Health who are here. Can you please stand up? National AIDS Commission. I would also like to thank all our Elizabeth Glaser, Global Fund, PEPFAR, and all our partners. We are in this together. Thank you very much.